have plenty of knowledge in medicine. The problems arise when we don't apply it. Welcome back to my conversation with Dr. Sean Khozin. This time, it's all about execution, what it actually takes to bring ambient AI into the clinic. First, we start with trust, mainly why clinicians are skeptical after the EHR era. We talk about rebuilding the EHR with tools that fit the workflow by starting small and proving value every day. We then dig into policy. First, what not to do, like another meaningful use type technology mandate. And then what does work, smart top-down action to make data more liquid, so entrepreneurs and researchers can build more responsibly on the best biomedical data sets. We move on to measurement, why it's time to move past lagging, blunt metrics like RECIST and move towards leading signals from real conversations so doctors can act sooner and with more confidence. Then we close with practical steps for clinicians, operators, and builders to move beyond ambient documentation and into decision-making. Not someday, but now. Let's get into it. We've never seen a tool in healthcare be adopted as fast as ambient.
Sure.
And, the reason why is because I think it touches on so many it solves a lot of the essential challenges, critical challenges that of healthcare delivery today. And, I think a lot of the discussion that I'm hearing about ambient is still in what is the ROI of AI? How much time are people saving with ambient? And look, I think all of that is super important, right? We need to figure out how to pay and justify for ambient. But, I think what I always like to challenge people to think about is in a world where, 90% of these conversations are recorded, what does care look like?
Mm-hmm.
Right. And that is what I think we should be spending our calories building. And so, we talk a lot about, yes, you could have ambient, but, ambient could also be analyzing the semantics of the conversation to try to flag any contextual flags that the patient might be sharing, but you're not picking up on. Or we can, run it through a behavioral screening that's, tracking vocal biomarkers, and do a PHQ-2 and, flag that to the physician without having them, think about it. These are like the things, like the type of care that we can be living in. And I feel like a very deep sense of responsibility because, I talk to, other founders that are building startups in this space. I talk to you, that is, so rooted and really an expert in like understanding all the research behind it. And, what I'm kind of coming to a realization to is that, this is the first time ever where this instrumentation exists at scale to bring all this research to life. And I feel like a deep sense of urgency and responsibility because I can see this type of care that we can be delivering, but we're not. And so, the question here is really like, what do you think is the biggest challenge, or what do you think is the biggest reasons why it's so slow to kind of get these technologies into the exam room and into the care stack?
Great question, Matt. And I think that's one of the unfortunate realities in medicine today, that we become very risk averse. And, everyone has their heads down. They're just trying to get through the day. And they don't want anything new, especially since physicians have had such a bad experience with electronic health records. They've become a little technology hesitant. So there's a lot of tech hesitancy in the medical establishment because, unfortunately, of the electronic health records that did not fulfill their promise. However, I think things are changing because, I'm going to go back to the history of medicine, where medicine and engineering were quite intertwined, in the late 1800s. Like today, if I told you that if I have developed a biosensor that can measure the electrical activity of your heart, and I'm going to use that biosensor to make life and death diagnoses, you would think I'm crazy. You would probably ask me to reach out to the FDA to have a meeting or have a few workshops. Let's develop a white paper and build consensus statements. And it would drag on for probably many years. Well, we developed that biosensor in the late 1800s. It's the electrocardiogram, and very quickly it moved into patient care. because clinicians and physicians were experimentalists. Every physician was experimenting all the time. And they were, in some cases, polymaths, in other cases, working closely with folks that today we would consider data scientists and engineers. We got a lot of quick wins at that time. And when things hadn't been fragmented yet, X-rays, another quick win of the sort of the amalgamation of medicine and engineering. Obviously, we took X-rays a little too far. We were using them to fit shoes at shoe stores. A lot of radiologists, unfortunately, ended up getting cancer. But that sense of experimentation, bold experimentation, gave us X-rays. Same thing with MRIs. And in a way, we're still riding that momentum, that wave. The first telemedicine conference was in the 1920s, and one of the topics was electronic remote transmission of electrocardiogram signals. So that was sort of what was on the mind of physicians and engineers at the time that worked very collaboratively and as a single unit, which is even beyond collaboration. They were a single unit. That is no longer the case because of a variety of different reasons. I'm a thoracic oncologist. I never envisioned being a thoracic oncologist when I went to med school. Everyone obviously wants to be a primary care physician. Then you realize that realities of practicing medicine are different. So you specialize and you sub-specialize. And that's what I ended up doing. In fact, when I went to med school, my specialty did not even exist, my thoracic oncology. But because you have to memorize so much we start to fragment care. So not only medicine and engineering have separated, different medical specialties are now working in silos. So and really, if you think about what we're all trying to accomplish, we're trying to organize information and then act on that information. That's basically it. And because because science has been advancing, that the amount of information has been exponentially growing, and it's created these silos. But at the end of the day, we're just trying to gather information and act on that information. Well, now with AI, especially the semantic content in conversations that occur between the doctor and the patient, which is how we gather our information, plus laboratory and imaging, and but really that what the patient tells you is a huge factor in decision making. That content can be structured, can be validated, can be quantified, because what a good clinician does, the reason the doctor-patient relationship is important is because in technical terms, essentially you are creating a mental image of that patient. And as the more you follow them, the more you get to know them, you have your own latent space of that patient. Well, that's very hard to do nowadays because physicians are just so distracted with things that, again, have little to do with patient care. But technology can create that latent space. In fact, your recordings, longitudinal recordings on a single patient can be used today, and you may have already done this, to create a latent space that is essentially clinical intuition. And that clinical intuition about that patient, we're talking about the semantic content, putting aside the digital biomarkers. So that latent space can be interrogated either by the clinician, or could be done autonomously and then delivered to the clinician to make important decisions for the patients, connections that were not previously made. So that clinical intuition is really the heart and soul of medicine, and the instrument that you're working with, capturing what the patients are saying, is really perhaps the most important element. And these are the most important data points. We've been talking about patient-centered drug development for many, many years, just have never had any tools to be able to capture what the patients are expressing in a reproducible and quantitatively valid way. Patient-reported outcomes, for example, questionnaires with like 100 questions. Patients, especially sick patients, they don't have the stamina, and why would you want to expose them to that? So that field has not even move the needle much on really understanding the patient's needs. But I think we're now at that inflection point. So very exciting that in a way, the way I think about your work is you are essentially capturing and creating that clinical intuition in the latent space of the longitudinal experience of patients as expressed by the patient themselves, which is exactly what we've always been after.
Yeah. I think that's such a beautiful way to put it. And like, it reminds me, when I think about the times when healthcare fails, right? I think, there's two kind of big buckets. Like one, either the knowledge does not exist, and two, the knowledge exists, but it's failed to be applied. And, I think what's interesting here is that with the information that we're capturing, and also I think a lot of the innovation just around, especially in oncology, like one of the big challenges in oncology today is like the amount of therapies that are being experimented with and the amount of therapies that are coming to market. And so I think with the data that we're capturing and with the innovation in the therapies, I think like the knowledge exists, right? Or it's that problem is more likely to be solved than the second problem, which is, the knowledge exists, but it fails to be applied, right? And that's a challenge, I think, based off of just a human constraint, right? Like, if you go to medical school 20 years ago, what is the half-life of that knowledge, right? How many times has the universe of medical information doubled ever since you graduated, right? And it's going to be an increasingly difficult challenge for physicians or just humans, just in general, not even physicians, to keep up with that velocity of information. And so I think, you touch on a very important dimension, which is like getting the latent space, right? Getting the information. But I think there's also another aspect of it, which is how do we apply that information and improve like the equity of healthcare and make sure that every physician that's seeing a patient is able to practice at the top of their license, regardless of where they are. And so, I just think it's super fascinating.
That's it's a great thing that you just said, practicing the top of your license. And I think liberating physicians would allow them to do just that. But obviously, it's not just decompressing them from all the time that they have to spend. It's giving them information that goes beyond this reductionist framework that we have. And again, there are technical ways of looking at this, going back to Claude Shannon's information theory, the way that, for example, we organize medical information into history of present illness and SOAP notes is very reductionist. It actually doesn't contain much information from an information theory perspective, but that says that data entropy is actually good. This wild and messy world of data, audio, video, you name it, that's actually has the most information, and mathematically can be shown. Obviously, information theory gave birth to computer science. And we do apply those principles in computer science, but also in aviation. For some reason, medicine has been quite risk averse, even though you may argue that the risk of landing a plane using biosensors in zero visibility with 230 passengers is probably higher risk than the risk that an individual clinician takes with an individual patient in the exam room or maybe even in the operating room. It's a cultural nuance that I don't believe is part of the fabric of medicine, because again, in the late 1800s, early 20th century, we were very experimental and really pushed the envelope. So I think we still have those memory muscles. We just have to awaken those sort of innate desires that every clinician has to really push the envelope for their patients. And I think you're doing that to a large extent with not only carving out more time for the clinician, but also giving and providing and creating a new data source that is beyond reductionist. It's quite holistic. And I think, people always complain about messy data. I think the more data, the merrier, because the messier the data, messiness meaning like entropy from information theory perspective. Because if we have the right tools to translate that data, that's progress. Otherwise, we're just doing the same thing.
Yeah. And we talked about it. I think, taking the reductionist approach makes sense because we didn't have the tools to make sense of more data. But I think now as these tools begin to exist, I think I think it changes the way you have to think about data, right? And it's going to be very difficult to step into the light of this innovation if we continue to rely on busy, burnt out physicians to document and structure and harvest this data, because it's always going to be subject to what they think is important and what they can remember, right?
Yeah.
And so, by having this kind of just stream of consciousness, or just literally from the recording of the conversation, it really, I think it opens up a very unique opportunity that we really need to figure out how do we get the full potential out of.
Right.
So
Yeah, and I think if we focus on, and I don't want to sound like a broken record, but really the doctor and the patient, because everything else in a way is noise. It's supposed to support that engagement. If we just focus on that and enhance that engagement and interaction and giving both the patient and the physician the tools that they need for engagement and for decision making, I think we're going to see a completely new healthcare system, which is designed around what actually matters. Yeah. And if we look at what we do today during a course of the day, again, a lot of that doesn't really impact the patient directly. There's a lot of administrative work. So automating that and really focusing on what happens between the doctor and the patient is perhaps the best way to improve outcomes and to really have a giant leap in outcomes. Because unfortunately, life expectancy is starting to plateau in developed countries. In the US, it's decreasing in certain patient populations. It's not because we don't have good science or we're not developing great drugs. It's how we're delivering the care that's getting, unfortunately, more and more fragmented. So these workflows, these dynamics have real consequences, and we're starting to see the signals at least in life expectancy. So I firmly believe that if we play our cards right, we can catalyze a major leap in life expectancy by just delivering appropriate care around the needs of the patient, the N of one.
Yeah. Yeah. I mean, the stat that for every 1 hour of patient FaceTime a physician has, they have to spend 2 hours administrating and documenting that care. Right.
Mm-hmm.
And if you just think about, they spend twice the amount of time documenting and, administering and doing all the back end work than they do actually spending time in front of a patient trying to understand all the signals that they can from that, who they're trying to take care of.
Yeah, so. Absolutely. And sort of that. So all the, an electronic health record is supposed to be is a repository of information that for decision making. That's it. And we've just made it so convoluted. I think we're moving in the right direction. I think if the same trends continue, we can start to see a rebirth of small practices, community practices, because you don't have to be part of a larger health system to have economies of scale. Because if you have AI capturing the information, organizing the information, and the cost of that starts to decrease, then we're going to see a lot of smaller community practices that are able to sustain themselves and really practice it the way they want to, helping their local communities. Healthcare is a local thing. It happens where you live. It's very hard to industrialize healthcare. It has to be local and based and designed around local needs. So I think there was a time that we were in that world, like 30 years ago, the majority of clinicians were in small practices. Now it's completely the other way around. But I think what could happen through automation is we're going to see smaller practices, private practices, individual doctors, maybe even more physician will be able to handle everything themselves because everything else is automated. They don't need economies of scale. uh, that they can start to build those community relationships again.
Yeah. I mean, we spend a lot of time, in community oncology specifically, and I think that is one of the most consistent messages that we hear is that,
Hmm.
the majority of cancer care is delivered in the community, and that's how it should be. But I think we spend a lot of time talking about like this is what healthcare should be, right? And just to kind of pivot the conversation a little bit towards how do we get there,
Hmm.
right? We talked about some of the challenges for sure, but I think if you were to if you were able to talk to all the physicians today and had to tell them one thing, like what would it be? Like, what would you tell them to try to open up the aperture and try to
Hmm.
get them to kind of adopt AI?
I think we have to demystify AI for clinicians, and really focusing not on the perceived risk, but the opportunities that exist, and really appealing to the sense of wanting to help patients, and frankly also protecting themselves legally. There's especially in the United States, the legal aspects of medicine are quite important. So it sometimes makes clinicians very hesitant and risk averse. So I think it's a function of demystification and building trust.
Mm.
In a way, you're already doing that, because a clinician who is decompressed from doing their notes after dinner, staying up until midnight, and they have to get up at like 4 a.m. to go back to work, they start to build trust with that tool. So I'm sure you're already seeing that physicians that are using your technology are starting to trust not just your tool, but this whole idea of incorporating AI into the various aspects of how they practice medicine. And I also think that the muscle memory is still there, that sense of experimentation and risk taking is part of the fabric of every clinician, because that's what really drives a lot of folks to, again, medicine. The idea that you're going to be in charge of and helping patients thrive and survive, and experimenting and doing your best to accomplish that. I think that's part of the muscle memory of every clinician. So I think awakening those as part of building trust with our new machines will go a long way. Because at the end of the day, it's just a matter of trust, and the fact that physicians have unfortunately been burned again by technology in recent years. So they, one has to convince them why this is not the same as the first implementation of their EHR. Why this is not the same as all the other tools that were promised to clinicians that unfortunately had unintended consequences. So there is a period of 20 years that has eroded trust in technology. But I think with tools like ambient, scribe, as physicians see the value and start to build trust, and these tools are demystified, I think it's going to take us to a completely new environment where we're not just more welcoming and more experimental, but we're able to adapt. And this is just a matter of adaptation, and maneuver our way through these new technologies. And if my hypothesis is right that we're going to see more independent practices, well, those individuals will have much more autonomy to adapt and maneuver their way through these new tools. And they can adopt what works best for them. At the institutional level, it's going to have to be top down. So, you still have those complexities, corporate complexities, basically. But at the individual clinician level, clinicians are very good at adopting very quickly technologies that work best for them. A good example is, actually, I was say that, I don't know if you probably never saw it, Hippocrates and the Palm Pilot. So the first Palm Pilot that came out, basically, and when Hippocrates developed an app for the Palm Pilot, immediately it replaced the physician desk reference, which was, like a huge book of all the drugs and doses. So every clinician had a Palm Pilot and, the early versions. So, that adoption of that tool and technology was a no-brainer because you didn't have to have the physician desk reference. You could actually look it up as you're seeing the patient. So that was something that helped clinicians, and they adopted it very quickly. The only place where we have robots now, very much engaged with humans, is in the operating room. These robotic surgery machines. So physicians are not inherently afraid of technology. It just has to fit in their workflow. So it does fit into the workflow of these robotic surgical machines do fit into the workflow of a surgeon that's trying to do a radical prostatectomy, but in a non-invasive way. So it's part of that intuition. Same thing with ambient scribe. I think that's part of our intuition because we're not trained and physicians are not made to be data entry people. That's not why you go to med school. So I think we need to bring those tools that are part of their intuition and compatible with their workflow, rebuild that trust. And I think that will place us in the optimal position to bring AI into various aspects of medicine.
Yeah, I think that's so spot on. Like, I think, even in my experience, this trust is the most important thing. And, being able to develop trust iteratively and, as self-proclaimed data nerd, I'm not a doctor, but, we build things in service of doctors, right? And one of the things that we learned is sometimes the best technology doesn't win, right? It needs to really be deeply embedded into the workflow. You need to have a proper change management process, and you need to be able to develop that, cult-like following for the product. I think the second thing, yeah.
And one thing, Matt, that we have a problem also in healthcare when it comes to technology, especially information technologies, because the standards are dictated top down. There's, for example, after the High-Tech Act, that gave birth to High-Tech Act, basically mandated electronic health records across all medical practices. First, it was voluntary and then fine. So all clinicians had to adopt electronic health records. The Office of the National Coordinator was tasked with defining the standards, and they did their best. And these were all well-intended people, but unfortunately, they were not clinicians. So we missed the mark. And I think part of that mistrust comes from the fact that, in order to develop a tool that's really works for the clinician, just like the robotic surgery machine that was developed with surgeons, for surgeons, we have to develop technology with clinicians, for clinicians, versus this sort of like top-down way that we've been implementing, for example, electronic health records. And I remember, right before the High-Tech Act, I, by accident, stumbled upon creating a platform as part of a company we founded that emerged out of our own practices because we're playing around with software and end up becoming a company. And we were beta testing it. And my own practice was the main beta testing hub, because that's how we thought you develop software. You test it with the end users, and then more physicians came, and we had a number of practices that were using the electronic health record essentially. And what we had was telemedicine. We basically were tweaking the platform to be able to accommodate the workflow of the clinicians. Unfortunately, what happened, after meaningful use, we all of a sudden had no need to satisfy the needs of the physicians. No beta testers needed. Yeah. And in fact, we were in beta testing mode for a couple of years, and they became meaningful use compliant in 2 weeks. And that was it. So we could monetize the platform. But unfortunately, what that meant was that we had to water down the platform. We had to take out, for example, telemedicine. We had a lot of workflows that were not compatible with meaningful use. So we had to plug those out. which was unfortunate because a lot of our physicians started to complain that our platform is getting worse and worse. Well, which I
The more
agreed with
feedback I give you, the worse it gets.
exactly, because when we became meaningful use compliant, I basically told my board that, yeah, our technology is now, sure, monetizable, but it's a clunky billing machine. And we're going to have clunky billing machines whereas we could have had technologies that actually advance and incorporate into the workflow. And what I actually ended up doing at the time, I was not relying on my own practice to pay the bills. I refused to adopt the meaningful use compliant version of our own platform because our patients loved it. They could do telemedicine, and the clinicians in my had two practices at the time really loved working with it. And I was like, I'll pay the fines, as long as I break even. I'll be happy because I don't want to disrupt the patients. I don't want to disrupt my colleagues. So it's ironic that I refuse to adopt a meaningful use compliant of our own technology, because the meaningful use version was just so bad and clunky. So I think that, again, has created a lot of mistrust. But, that's water under the bridge. I think we're in a new world right now where you're building trust with a new generation of clinicians who are going to carry the torch.
Yeah, I mean, I think it's interesting. I mean, that's an interesting, case on how, regulatory influence, changes the outcome of something, right? And so, and I think it poses a really interesting question because, what technology is strategic enough? Like it's so important strategically that we make this paradigm shift as a collective whole that should require something like a regulatory influence. Whereas, something is, maybe strategic, but it's still discretionary, right? And just to kind of touch on that, I'm curious to get your take because, when we think about AI, I think at a national level, we think about as a critical technology that, us as a, country, and a society need to really kind of move towards. Right. And I think for healthcare specifically, it's important, right? Because, we've talked about all the challenges with healthcare and healthcare delivery today. And a lot of these problems are going to be solved with AI. And so, maybe this is just a hot take or a prediction, but what do you think? Do you think the government has any influence on, potentially doing a meaningful use style thing with AI?
Right. Well, frankly, I think the federal government in the U.S. has learned tough lessons following the High-Tech Act. So they're very cognizant of not doing massive top-down technology efforts that could have unintended consequences, even though, this is not much talked about. But for those interested, Fortune magazine did an investigative report back in 2019 called Death by 1,000 Clicks.
Yep.
And it's an eye-opening account of the implementation of electronic health records, where the architects of the High-Tech Act and meaningful use were in that article and admitting, the mistakes that they made. So I think that created a culture in federal government, especially when it comes to technology, that let's not make these sweeping top-down mandates. Now, there's an issue here because right now with AI, we do need top-down action. We need policy, but we need smart policy that empowers entrepreneurship. What makes us in the U.S. Special and our superpower is our ingenuity and entrepreneurship. However, we need to create conditions that can catalyze and empower entrepreneurs. And I think more or less what the signals I'm getting from DC today is that folks are thinking that way and very hesitant again to make top-down decisions. But there are areas such as creating data fluidity and liquidity where I believe top-down decisions can go a long way. For example, the FDA and NIH has the best biomedical data assets in the world, and being able to organize that data in a way that it can be used responsibly for AI model development can change the world. And that would require top-down smart regulation and smart policy making. So it has to be a balance. I think trying to control sort of the individual behavior of, for example, physician is never a good idea. And we've done a lot of that, unfortunately, throughout the past couple of decades. And those are things that we're now peeling back or replacing with AI, frankly. But when it comes to creating conditions on which innovation can flourish, such as creating data fluidity and data liquidity, I think top-down policymaking is the best way of getting there. And again, I'm seeing hopeful signals coming from DC, but it's also, I think our individual responsibilities to demand for that the kind of framework from our politicians and our decision makers inside the Beltway, because my experience at the FDA was quite educational, and one of the things I learned was that there are agencies like the FDA that are very cognizant of the unintended consequence of top-down action, and they're very much in tune with what the community wants and what that consensus is, and then they align themselves with that consensus. For example, a lot of the endpoints that we use in drug development today, people always think that, FDA mandated them. FDA never mandated any of these endpoints. They aligned themselves with the consensus that the community had established. And most of the endpoints that we use today, whether it's LDL or progression-free survival, they emerged out of the consensus of the community that these are meaningful endpoints. And now it's our opportunity to generate consensus around what we want our policymakers to do, and then express that in unity. Because what certainly won't work is when FDA hears multiple different ideas from multiple different stakeholders. That's not consensus. That's not, so that basically leads to inaction when it comes to regulatory decision making. But, we have an opportunity and frankly, an obligation to generate consensus around those critical themes that we want our policymakers to enact.
I couldn't agree more, and you couldn't have said it any better, Sean. I think especially in our conversations with how we think about the importance of the digital biomarkers and the power of voice. And, I think we spend a lot of time also talking about how a lot of the endpoints today are lagging indicators, right? And how do we, start looking at leading indicators and doing it at scale and doing it in a way that's actually robust and not just some sort of, reported outcome that could be really subjective. And so, I agree. It's our responsibility, and that's why we're here talking about it, right?
Right. No, absolutely. And another thing that I think a lot of folks, especially in the technology sector, sometimes try to adapt all of their tools to what we call gold standards, and I think that has done everyone a disservice. Really, if you think about it, there are no gold standards. Every standard is to be questioned. In fact, if we're not questioning our gold standards, then we're not making any progress. And really, I cannot think of anything in medicine that is an irrefutable law of nature. And if we think about, for example, how we examine the size of a tumor on a CT scan, we use a standard called a RECIST criteria, which came out several years ago, and now research shows that it's a very blunt tool. But we still use that metric, that standard, to approve oncology drugs. Now, the irony here is that nobody in the real world, oncologists do not use RECIST to deliver care or administer therapy. They use their intuition, they get a general sense of the lesions on a scan. They look at the patient's symptom, how the patient is doing, how their affect is. And then they make a treatment decision. Should we continue chemotherapy? Should we continue treatment or not? Because rarely you have a patient, especially in the metastatic setting, where you look at the scan, you're like, oh, wow, this patient has completely responded. Or no, this patient is clearly progressing. It's always, some lesions are smaller. And so you have to make a clinical decision. So nobody uses RECIST in the real world. So that disconnect is significant, but it's not obvious to a lot of, for example, AI model developers in the DICOM world that I've talked to that are training their models. And the ground truth is the RECIST criteria as annotated by radiologists. Well, that is the best way to have a model that's no better, probably even worse than a good radiologist. So I think, we need to start to rethink our gold standards, what the ground truth is, and really start to push the envelope. And I would take that even all the way to how we essentially classify diseases. That's in my field, thoracic oncology. We look at a biospecimen that we take from the lung, and I look at it under the microscope. I look at the size of the cells, and if the cells are small, then that's a category based on that visual phenotype, small cell. If the cells are not small, they're rather heterogeneous. So we basically came up with a word. We basically just made it up, non-small, because we didn't want to say large. So, and in the 1960s, WHO codified that as a histopathological criteria. Well, now if you have an AI innovator working on digital histopathology and they're looking at non-small cell as the ground truth, it's not the ground truth. It's a linguistic definition based on somebody looking under the microscope. They didn't want to call it large, and we made
I always wondered why it was called non-small.
Non-small, because we couldn't say large, because the cells are not small, but there are varying sizes. So, granted, that visual phenotype is quite interesting. It does tell you a story, but it's not the full story. It's just a very small slice of a much bigger pie. And the real answer is in the mechanism of disease. So, I think we should, everyone who is trying to develop any tool in medicine, any biomarker or any prediction engine needs to go beyond what we call gold standard.
Wow. Sean, we can go on for hours, and I really
right. No, I think this is great.
your perspective.
Go on for hours.
But truly, it's always so special every time I get the chance to speak with you and learn from you. And I really hope the audience learned something new today. I just want to thank you again for being a guest on the podcast. And is there anything else you'd want to cover?
No, thank you, Matt, for having me. This was a fantastic discussion, and I'm looking forward to continuing the dialogue off camera.